Hello, everyone. My name is Lori Fackler, and I will be presenting my scholarly project, Improving Medication Adherence through Comprehensive Medication Reconciliation to fulfill the requirements of my Doctor of Nursing degree at Maryville University, St. Louis, Missouri. My committee members include my chair, Dr. Robin Hendricks, my second reader, Dr. Lisa Sturr, and my community member, Dr. Jill Stevens. I am grateful for their encouragement and expertise throughout the project. This project stems from many years of practice and a common yet serious issue that seems to have worsened over the years rather than improved. Anyone who has been in healthcare knows exactly what I am talking about. Providing safe and effective care requires knowledge of an accurate medication list for the patient receiving care in all circumstances, whether reviewing testing, hospital follow-ups, sick visits, or wellness visits. You know, the little blue pill, the one I take at night, or, I don't know, my husband sets out my pills, are all too often the response when trying to review a patient's medication list. Although I felt this problem happened frequently, I was unaware of the actual frequency until this project. Low awareness by providers of adherence failure to medication treatment plans contributes to the problem. The objective of this presentation is to inform the viewers as well as provide a solid solution for this unfortunate common issue of inaccurate medication lists when trying to provide care for patients. Although brought to light more than 20 years ago by the Institute of Medicine, medication-related errors continue to occur and can occur at any step of the process, from prescribing to actual consumption of the medication. An important consideration is that a comprehensive medication list reconciliation can take over 21 minutes. This project focuses on the importance of an accurate patient medication list prior to initiation of treatment and the intervention of comprehensive medication reconciliation to ensure the most accurate list exists. Prior to this project, there was no consistent procedure for medication reconciliation at the project site. Requests for the patient to bring in their medications failed for many reasons. You are dependent on the patient. The patient may forget to bring the medications, only bring in some of the medications, bring old bottles, or purposely omit some medications due to feelings of embarrassment. The process of completing a form listing medications often lacked accuracy for the same reasons. Patients may not view inhalers, injections, patches, or nebulized medication as medications and fail to list them. Patients on narcotics may omit this information in an attempt to gain additional medications. These failures to obtain an accurate list resulted in the study topic. The study aimed to answer if medication errors in adult patients seen in the primary care clinic who completed a medication reconciliation protocol reduced medication errors compared to the standard practice of a patient-provided medication list. This intervention will be evaluated for its significance and role in reducing medication errors, thereby increasing medication adherence. Secondary aims included improving quality of life, decreasing morbidity, reducing adverse reactions, increasing patient involvement in their own care, and educational opportunities regarding medications. The prevalence of medication errors is an estimated 1.5 million events annually in the United States, resulting in increased morbidity and mortality, as well as an economic burden of $290 billion, which is 13% of the U.S. healthcare annual expenditures. The practice of patient-provided medication lists was found to involve more than 50% of the patient medication charts, which is in line with previous studies. Reasons for inaccuracies are many and may include the advanced age of patients, health literacy, polypharmacy, cost, interoperability issues between EMRs, complex networks of providers, and limited staff time. The benefit of a medication reconciliation protocol is to increase the accuracy, reduce the errors contained within the list, and ultimately reduce non-adherence. Non-adherence, described as the failure of an individual to follow a prescribed therapeutic regimen, can reflect incorrect medications, incorrect dosing, and not taking the medication when prescribed. Additionally, patients with chronic diseases fail to adhere to their medication treatment plans 50 to 60% of the time, resulting in poorer outcomes. Another factor, multiple providers prescribing medications necessitate the coordination of accurate medication lists. Finally, hospital readmissions related to poor medication adherence are estimated at 30%, requiring the transition of care to contain an accurate medication list. Continuity and communication are key in these processes. The comprehensive literature review was completed using the Cumulative Index of Nursing and Allied Health Literature, known as CINAHL, the Cochrane Database of Systemic Reviews, EBS-CO Host, Medline, PubMed, and ProQuest. 10 articles were used for theme development for the scholarly project. The literature review explores the significance of the errors, the setting of the errors, and the interventions attempted to reduce the errors and improve accuracy. 3 themes were identified for the project. The first involved medication errors and their impact on healthcare as a leading preventable or avoidable error in healthcare. As discussed earlier, the impact on a patient's health and the health of society is significantly impacted by medication errors. The next theme involved the importance of identifying the sources and types of medication errors, as well as the interventions for medication reconciliation as they related to the research completed thus far. Primary care providers are in a unique position to identify and correct the errors contained in adult patients' medication lists because of the often long-term patient-provider relationship. The final theme concerned the implications for patient outcomes, which included reducing adverse outcomes and improving patient outcomes. Gaps in the literature did not include any conclusive interventions to promote change in the medication reconciliation process. The discussion revolved more around the identification of the problem in the many different settings of healthcare, such as outpatient clinic and hospitals, and the need to resolve, however, with no direct recommendations. This scholarly project followed the theoretical framework that best related to its intervention and goals, which was Becker's health belief model. There are 6 elements that affect behavior, which include perceived susceptibility, perceived severity, perceived benefits, perceived barriers, cue to action, and self-efficacy. These relate to the motive to avoid illness or to get well if already ill, and the specific action related to health to prevent or cure illness. A patient will be more inclined to participate in medication adherence if they perceive a benefit to their health by either prevention of complications, controlling an illness, or curing an illness. The intervention involves patient involvement through the prospective interview and follows with the belief that once the patient understands the true importance of medication reconciliation, they will remain motivated. The actual process of medication reconciliation provides an excellent opportunity for the patient to gain knowledge about their medications and the reasons for taking medication specific to their situation. The design was a mixed, retrospective EMR chart review of the medication list with a prospective patient interview confirming the list, followed by a pharmacy claim review for each participant. The setting was an adult primary care clinic in Central Florida. The sample size was 72 adult primary care patients who were 18 to 89 years of age, spoke and understood English, and were on at least one prescribed medication. Patients with a diagnosis related to cognitive difficulties were excluded. Full IRB approval, site approval, and informed consent were obtained prior to data collection. All patients on the provider schedule were evaluated for inclusion and exclusion criteria. The data was collected prior to the intervention and after the intervention and included the number and types of medication errors. Data collection occurred from July 23rd to August 1st, 2024. For the retrospective portion of the study, the provider generated the EMR medication list from the patient's EMR chart. The prospective portion involved a patient interview and pharmacy claim inquiry for medication fills for the prior 6 months to reconcile the medication list. The time limit of 6 months was used to capture the most realistic medication profile. Participants were asked to review the EMR-generated medication list with the provider, and the data was recorded on the author-created datasheet. The process involved going from the top of the list to the bottom of the list to confirm the accuracy of the medications on the list. This was followed by the pharmacy inquiry, which provided the listing of all medications, the dosage, the amount prescribed, as well as who prescribed the medication. The identified errors were tabulated according to the category as well as the total number of errors recorded on the data collection sheet. There were 3 categories of medication errors: errors of commission, errors of dosage, and errors of inappropriate use. Data collection was completed in an ethical and confidential manner. Patients were assured their care would be the same whether they participated or did not participate to remove bias. Finally, because the data was abnormally distributed, the Wilcoxon signed rank test was used to compare pre- and post-medication error data with the assistance of Maryville statistician Dr. Mark Pauls. The findings indicated there was a significant reduction in the number of errors in all 3 categories of medication errors. The error of inappropriate use occurred most frequently, with a total of 193 errors and reflected medications that were included on the EMR generated list, but the patient no longer took or should not be taking. This was followed by errors of commission occurring 40 times and indicating medication the patient was currently taking, but that was not on the EMR generated list. The last category, errors of dosage, were the least identified errors and occurred 8 times. The total number of errors for the 72 participants was 241. On average, the medication lists were more accurate with a median of 0 after the intervention than before, when the median was 3.00, as shown in the figure. The median of the negative ranks was larger compared to the positive ranks, which suggested that the values of post-intervention errors were smaller compared to the baseline measurements. This was statistically significant when analyzed with the Wilcoxon signed rank test with a Z of negative 7.088 and P less than 0.001. Comprehensive medication reconciliation is an effective intervention to strengthen medication adherence in adult primary care patients. It involves a review of the EMR, patient interviews, and pharmacy inquiries. The strengths of the study include the mixed design, consistent and rigorous data collection, minimal cost to implement, patient involvement, and at the completion of the intervention, the patient was provided with an accurate medication list. This list could then be used by the patient and other providers clinics, etc., that the patient may interact with. A patient's compliance to filling medications on time could also be ascertained. The pharmacies used, as well as the names of other prescribers or providers. Additionally, this study is generalizable and sustainable. Limitations of the study include the shortened data collection timeframe of 3 weeks. Since the site has a seasonal population, they were not included. Internet connectivity was an additional barrier faced. Due to the number of errors in some of the EMR medication lists, the allotted time was not enough and additional time was required. Finally, pharmacy reporting policies differed, and for some, they were not required to report for 48 hours. So in those instances, the accuracy of the pharmacy claim could be questioned. For nurses, medication reconciliation provides an effective method to create and maintain an accurate medication list as they care for patients. Day-to-day activities that include prescription refills, drug interaction checks, and education require an accurate list. With advanced practice registered nurses, medication reconciliation supplies an accurate medication list to be used when providing care to patients. The medication list is key to many things, not only what patients are taking, but why. For patients who supply limited information in their intake information, it provides a great starting point. For example, if a patient is on Eliquis, a blood thinner, and there is nothing in the history, it is a cue to ask why the patient is taking it. Maybe for blood clots, an irregular heart rhythm, or something else. On the other end, if you see a patient with a diagnosis and review the medication list and there's nothing for that specific diagnosis, it will lead you to further inquiries of why that particular disease is not being treated, which will dictate further treatment. An example of this is a patient with a diagnosis of diabetes and is not taking any medications for diabetes. This could be explained by diet-controlled treatment, intolerance to therapies, or reluctance. Additionally, you can look back at previous medications tried and for how long, if you are able to view the history. Many times, patients do not remember what has been tried in the past, and this would prevent duplication of a failed or poorly tolerated therapy. An accurate pharmacy list will also provide valuable information, such as other providers, so that specialties can be identified. Patients' compliance with their medication regime can also be evaluated. Are they filling their medications on time? This all goes back to the premise that any care provided requires accurate knowledge of the medications a patient takes as well as how they take them. For the healthcare system, an accurate medication list contributes to best practices during all stages of care and by all involved in patient care. Accessibility to an accurate patient medication list provides consistent, quality, and safe care. This will result in decreased healthcare expenditures, decreased morbidity and mortality, and increased productivity that may have been lost due to chronic illnesses, such as time lost from work. Population health in general improves with evidence-based care, which this intervention provides. To summarize, this DMP project identified a pervasive problem that affects every aspect of patient care with long-ranging implications. The quality improvement protocol of medication reconciliation through a standardized and consistent process was successful in reducing medication errors, thereby improving medication adherence for adult primary care patients. This supports the incorporation of comprehensive medication reconciliation as a standard of care that is necessary to improve patient outcomes, reduce costs, and improve population health. Future research could include more diverse populations, capabilities of a more centralized database, as well as trying to better understand the barriers currently in place that prevent medication reconciliation, such as limited resources and providers' reluctance. Understanding that correcting the list early would reduce duplication, clarifications, and staff time trying to track down discrepancies and correcting mistakes, which would actually reduce resources, could serve as an incentive for providers as well as administrators in healthcare facilities. Primary care patients tend to be more complex and are at increased risk for adverse events related to medication errors, and it is the primary care provider who serves as the gatekeeper to provide safe and quality care. As this project was completed, the ultimate goal became very clear, which would be to have a centralized database accessible to all who participate in patient care. Even though this would be a heavy lift, the framework is in place in the format of controlled substances, inquiries available in most states, such as eForce in Florida. In the state of Florida, the Controlled Substance Reporting Program receives funding from grants in the state. Pharmacies are required to report within 5 days of filling controlled substance prescription, and prescribers are required to review the generated report, which contains the prescription fill history and risk score. Another advancement seen most recently was the capabilities of Starlink, which is a network of satellites that provide internet in remote locations, such as in the areas of North Carolina that were devastated by the hurricane and became isolated, making this a very promising tool for remote areas receiving care. Rural areas as well as community mobile practices often have limited internet connectivity, limiting the care that could be provided. With the technological advances of the internet, even in these remote areas, patient care would improve. The two capabilities of an existing framework and increasing internet access can make the goal of a centralized system attainable. In closing, this DMP project improved my knowledge and leadership skills and informed me of what my future role will be. Taking the data which supports evidence-based practice from this study and disseminating it to other practitioners and appropriate policymakers will hopefully be transformational, which is what it is all about. Thank you for your time. Please feel free to contact me with any questions. The final slide contains the references for the presentation.